Welcome you all in this session. This is the session of Undergraduates Best Paper Award. I would like to call my first presenter, Zahira Nayab Malik, for her presentation. She is not here. So Dr. Saira Azhar, please come forward.
Assalamu alaikum, my dear audience. Let me start by introducing myself. I am Saira Azhar, a fourth-year MBBS student from Rawalpindi Medical University. Let me tell you that I am very excited today to be here and talk to you about a very specific niche in the field of regenerative medicine, that is, role of stem cells in corneal regeneration and repair. Most of you might already know that corneal diseases are a leading cause of vision loss worldwide, and there are not even a lot of treatment options available. Like if I talk about the transplantation procedure, yeah, it is a successful procedure, but it has a lot of limitations and risks associated with it, like the scarcity of donors available and the transplant rejections. You can see the stats here, and here you can see that the subsequent regrafting has even a higher rejection rate than the primary one. But do we just stop there? No. But this presentation will highlight the critical contributions in the field of regenerative medicine with the aim of corneal reconstruction after the injury or disease. You can see here that the potential of stem cell therapies lies in the fact that they can generate the healthy cells, replacing the ones that have already been damaged by the disease or the injury. You can see here as well that the mesenchymal stem cells have a wonderful capacity to be differentiated into various cell line types. Like if I specifically talk about the corneal stem cell types, this could be differentiated into the corneal epithelium, corneal stromal keratocytes, and the corneal endothelium as well. But before I dig in further, I would like to tell you here that my specific focus is on adipose tissue-derived mesenchymal stem cells. Now, most of you might be wondering that why is that? It's basically because of 4 good reasons. Number 1 is that they are easily accessible, and that too with the least invasive procedures, like the liposuction or the lipectomy. Number 2 is the autologous fashion from which those could be extracted from the donor, so thus reducing the risk of immune rejections. And number 3, that they'll suppress the inflammatory responses, thus reducing the risk of scarring. And number 4, that they'll secrete specific growth factors that enhance the corneal epithelial proliferation. Now I would like to talk about the preclinical studies, where I would like to specifically mention the work by Park, who demonstrated the safety of these adipose tissue mesenchymal stem cells when he transplanted these stem cells in the eyes of his animal model. Moreover, he also discovered that the T cell proliferative response was found to be suppressed. Another study was conducted back in 2016 by Bittencourt. He also transplanted these stem cells in the eyes of canine eyes with a dry eye disease. He noticed that the lacrimal tear production was significantly improved. You can see here as well by the preclinical evidence which shows that there is significant increase in the tear production in the corneal epithelial markers, and there is a significant decrease in the neovascularization, corneal opacity, and the inflammation as well. Now about the ongoing clinical trials, my colleague Anusha Idnan here will take you through it.
So currently, there are 12 clinical trials in which mesenchymal stem cells are being used to treat the damaged corneal epithelium. 4 of them propose using adipose-derived mesenchymal stem cells. And as you can see, the outcomes of these therapies shows that there are no adverse signs and symptoms. These are the anterior segment optical coherence tomographic images and slit lamp images from a patient of keratoconus before and after the autologous mid-stromal adipose-derived stem cell implantation. You can observe the improvement in the post-operative pictures, that their density and the severity is visibly decreased, and there is corneal clarity. This study was done in rats in which activated omental cells and adipose tissue-derived stem cells were injected in the corneas of the rats, and one was the control group. The slit lamp images of these 3 groups were compared, and which shows much better corneal clarity and decreased amount of the corneal neovascularization in the cell-injected groups. The graphic representation of the same result shows that the area of neovascularization are clearly decreased in the cell-injected groups, which suggests that there are inhibitory effects of these kind of stem cells on the corneal neovascularization. which is a good thing, of course. So concluding this, we can say that these encouraging results indicate that the successful implications of the adipose-derived stem cells in the corneal regeneration is very helpful. And moving forward, if there are more clinical trials using stem cells in this direction, will lead to novel and effective mechanisms for the treatment of corneal pathologies. Thank you.
Thank you, Dr. Saira, for such an informative talk. Now I would like to call Dr. Zahira. She is not here. Dr. Mohammed bin Humayun.
Assalamu alaikum, everyone. My name is Dr. Mohammed bin Humayun, and I'll be giving a presentation on ocular myasthenia gravis. Shown here is the sequence of my presentation. I'll begin with the case presentation. So, my patient, an 18-year-old male resident of Jhang, presented to AFIO on 20th October 2023. He presented with complaints of drooping of left upper eyelid and double vision in the vertical gaze for 10 days. On further inquiry, the patient was in usual state of health when he noticed diplopia and ptosis of left upper eyelid for 10 days, which was not associated with any trauma, pain, headache, vomiting, or generalized fatigability. There was no ataxia, dysphagia, migraine, or hemifacial paralysis. The past history was not significant. The patient is a non-smoker, non-addict, and belongs to middle socioeconomic class. General physical examination, once again, nothing to note here. And the systemic examination was unremarkable as well. Coming on to the ocular examination, we observed a visual acuity of 6/6 in both eyes. The anterior compartment of the left eye was remarkable in the sense that there was severe ptosis, while the right eye was unremarkable. On further examination of the ptosis in particular, we observed that the margin to reflex distance was 0.5 millimeter in the left eye, and the palpable fissure height was 3.5 millimeter in the left eye, which in contrast with the normal values is greatly decreased. In addition to that, the left superior rectus showed underaction, and there was vertical diplopia on levo elevation, which was fatigable and variable. In addition to that, we observed a positive Kogan twitch sign, and there was marked fatigability at 20 seconds in particular. We performed an IcePack test, which showed improvement after 2 minutes, and the Hess chart showed restricted movement of elevator muscles. On the basis of all this information, we concluded a differential of ocular myasthenia gravis, thyroid eye disease, and chronic external ophthalmoplegia. We went along with investigations, and the anti-acetylcholine receptor antibodies were raised. The MRI and CT scan was unremarkable of the chest. The relevant autoimmune profile once again was negative, and the thyroid profile was also within normal limits. The EMG studies that we conducted did not give any sign of generalized myasthenia gravis. However, it's important to note that it cannot rule out ocular myasthenia gravis. So a definitive diagnosis of ocular myasthenia gravis was made. We started off the management with counseling the patient regarding the treatment and the follow-up. He was started on pyridostigmine 60 mg TDS, which is the anticholinesterase agent, and Celsep was added in conjunction after consultation with neurologist, which is an immunosuppressant. On follow-up visit after 4 weeks, there was marked improvement in both ptosis and ocular motility, as shown in these images. So, on to the case discussion. Myasthenia gravis. We've all heard about it in physiology, particularly, but it is an acquired autoimmune disease in which antibodies are formed against acetylcholine receptors, which results in impairment of neuromuscular conduction, which presents itself in the patient as weakness and fatigability of the skeletal musculature. There are, broadly speaking, two types. There's a generalized form and there's the ocular form. The ocular form is localized to the orbicularis oculi, the levator muscles, and the extraocular muscles, while the generalized form will involve the bulbar, limb, and respiratory muscles as well. It's important to note that the ocular form can, down the line, convert into the generalized form. This is just a diagram to highlight the pathophysiology. Clinical manifestations of ocular form is usually limited to ptosis and diplopia, as is the case in our patient. However, if it is generalized form, it will also include dysphagia, dysarthria, and even respiratory distress in case of myasthenic crisis. So there is a risk, as I mentioned before, of its converting to generalized form, which varies between 20 to 85% across different studies, which can be contributed to various factors. And a differential diagnosis can include both a lot of things: myotonic dystrophy, chronic progressive external ophthalmoplegia, Miller-Fisher syndrome, and oculopharyngeal dystrophy. So the investigation, this investigation I find particularly interesting is the ice pack test. You basically place the ice pack on the eye for 20 seconds, and if there's an improvement in ptosis by 2 millimeter, that means it's positive. It's highly sensitive and highly specific for ocular myasthenia gravis. The antibody testing can be done, which includes acetylcholine receptor antibodies, MuSK antibodies, striational and calcium channel antibodies. Pharmacological testing is not usually performed, but it can be kept in your repertoire. And the EMG, in particular the repetitive nerve studies and the single fiber electromyography is used. The single fiber EMG is more sensitive. We have to rule out autoimmune diseases, thyroid disease, and thoracic imaging should be done as well. Treatment involves, once again, as I mentioned, the acetylcholinesterase inhibitors, steroids, and immunosuppressive therapy. Surgical treatment is not usually required for in particular for the ocular form. In conclusion, the literature review, one study which I wanted to present in particular was this study conducted in Tangdu Hospital in northwest China, which emphasized the point that out of 223 patients of ocular myasthenia gravis who were receiving immunosuppressive therapy, still 17% did progress to the disease, generalized form of the disease. This is also a current up-to-date guidelines which mention the separation in the sensitivities of different diagnostic tests between the ocular and generalized form. And this is a study we conducted on our own in AFIO. So in conclusion, the complete workup of new onset ptosis should be done to rule out any underlying sinister pathology. The patient with ocular myasthenia gravis needs lifelong follow-up due to increased risk of conversion to generalized form, and the medical practitioner should be aware of the diagnostic and therapeutic differences between the ocular and generalized form. These are the references. I thank you all.
Thank you, Dr. Mohammed, for such an informative talk. Now I would like to invite Dr. Usama for his presentation.
Assalamu alaikum. My name is Usama Shabir. I am a fourth-year medical student at Rawalpindi Medical University. Today I'm going to discuss an interesting topic which over the recent years has gained a lot of importance in the field of medicine and especially ophthalmology, and that is nanotechnology-based ocular drug delivery. The eye is a sensitive organ. It has multiple barriers and defense mechanisms which have made targeted drug delivery a difficult task. The traditional methods which are being currently used in the clinical practice have certain limitations, and they often fall short in achieving the optimal drug concentration at the target site. However, nanotechnology, it has provided us with a groundbreaking advancement in the field of drug delivery because it has increased the efficacy and safety of drug delivery. Now in this slide, as we can see, these are the traditional methods that are being used: the topical administration, intracameral, subconjunctival, intravitreal, and systemic. Now all of these routes, they face certain barriers, which can be classified into 4 categories. The static barriers, which include the corneal epithelium, corneal stroma, sclera, and conjunctiva. The dynamic barriers include tear turnover, reflex blinking, and nasolacrimal drainage. The metabolic barriers are the enzymes and the efflux pumps, and the intraocular environment includes 2 barriers, the blood aqueous barrier and the blood retinal barrier. Now all of these barriers decrease the bioavailability and the penetration of the drug till the target site. The different types of nanocarriers which are present in the market and are being used include nanomicelles, nanoparticles, the microemulsions, dendrimers, and liposomes. A few important ones have been shown here. For example, the gel systems, they have an improved retention. The dendrimers have improved solubility. The micelles have an increased absorption, while the liposomes have corneal accumulation. The nanoparticles have an increased penetration. There are many advantages of using nanotechnology-based drug systems, and these are targeted delivery, reduced drug degradation, and lesser side effects. Now these 3 points increase the bioavailability of the drug at the target site. The prolonged drug release, however, decreases the dosage frequency and improves the patient compliance, which overall is a plus point. Now this is a list of all the FDA-approved drugs which have been used along with nanocarriers over the past. A few important ones include azithromycin and cyclosporin A, both of them which have been used in the form of nanomicelles to treat different conditions like the dry eye disease, keratitis, and the eye inflammation. The mechanism of action of these nanocarriers is divided into two parts, the uptake mechanisms and once inside, the drug release mechanism. I have generalized it. For example, there are certain nanoparticles which enter the cell by endocytosis. Because of their small size, they are mistaken by the cell as a cargo, and thus they go inside. There are other nanoparticles which can passively diffuse through the cell membranes. Now, once inside the cell, the drug release mechanisms are also a bit different. They vary for each type of nanocarrier. Some of the nanocarriers, they are made up of biodegradable material, and they break down inside the cell and release the drug. While in some cases, the drug is loosely attached to the nanocarrier, which slowly is released over time. And there are certain nanocarriers which release the drug in response to specific triggers. So overall, the key factors that influence the uptake and release are size of the nanocarrier, surface charge, chemical composition, and the concentration. The limitations of nanotechnology are approval of the formulation is a complex process and it is time consuming. There are concerns regarding the potential safety. The production procedures, however, sometimes change the properties of the nanocarriers that are being studied. It is overall an expensive process because rare materials are used and there are multiple trials that are to be conducted. Overall, due to these reasons, only a small number of effective nanomedicines are present in the market. The future perspectives are that continuous research and clinical trials are still being conducted to make safe and compatible nanocarriers. Nanotechnology, besides drug delivery, has been also used in gene therapy and in imaging techniques. The overall global market of nanotechnology is expected to reach to billions of dollars within the 5 years. So this is it from my side. Thank you.
Thank you, Dr. Osama, for teaching us nanotechnology. Now, I would like to invite and Dr. Munaqib Ali for his presentation.
Hello. Respectable professors of the Ophthalmological Society of Pakistan, I, Munaqib Ali Akbar from 4th year RMU, and with me, Uzair Nabil, also from 4th year RMU, present to you our salutations and greetings. Assalamu alaikum. Today, the topic of my presentation is advancements in treatment options for wet age-related macular degeneration. So let's have a brief introduction. What is age-related macular degeneration? It is a degenerative disease of macula causing irreversible loss of vision, a type of which is wet AMD, which is a chronic eye disease causing severe central vision loss due to formation of new blood vessels that leak fluid under the macula, usually occurring in patients that are 50 or more than 50 years of age. Its pathogenesis is as follows: that there is first choroidal neovascularization, then there is abnormal blood vessel growth, which extends into the subretinal space, and the vessels are leaky, resulting in exudative ARMD, and ultimately fibrous scar formation takes place. What if you wake up one day and you cannot even recognize the face of your child, and this is how the vision is presented, and so these are the symptoms that suddenly appear and the patient is miserable enough. And these are the symptoms: that there's distortion of blurring of central vision, straight lines appear wavy, dark spots appear, and the risk factors associated with it are that there's advanced age, there's genetics and family history are also linked to it, smoking is also a reason, and certain cardiovascular risk factors are also present. Now we come to that current treatment options, which emphasize on that why it is need of the hour that we need advancements in treatment for wet AMD. For example, there are anti-VEGF injections, which are very effective in blocking the growth of new blood vessels due to vascular endothelial growth factor, but they occur in repeated injections, which is very miserable for the patient, and we as doctors have to reduce that misery. Laser is also present, and photodynamic therapy are also somewhat effective. So now as we come to the main point, the advancements in gene therapy which target specific genes involved in the disease, and that gives a better prognosis. Two trials are worth mentioning. Firstly, there is the ADVM022 trial in which we gave a single Ixo-Vec injection. Point to be noted, single Ixo-Vec injection that reduces the need for multiple injections and give the retinal pigment epithelium its own ability to synthesize the aflibercept, which then helps to reduce the wet AMD. Secondly is the RGX-314 program, which also functions by a similar mechanism. The only difference is that it causes the production of fraction antibodies, which then helps to stop the growth of new blood vessels by inhibiting VEGF and thus stopping wet AMD. In short, a single dose. Now I would like to hand over the baton to my colleague here. Thank you.
Assalamu alaikum everyone. So moving forward towards the further advancements, we have advancements in treatment for wet AMD that include cell-based therapies and complement inhibition. So they are also somewhat effective in place of the gene therapies. So advancements in the drug delivery system include ranibizumab port delivery system that is small, durable, refillable, and non-biodegradable drug. And we also have corticosteroid implant. Of course, they reduce the use of multiple uses of the anti-VEGF injection site stated by my colleague here. So let's move forward towards the surgical innovations, and we have macular translocation surgery. The macula can be shifted from its original location to another site to improve the vision. We have implantable miniature telescope that can improve the central vision, as stated by my colleague, that centrally the vision declines. And thirdly, we have retinal pigment epithelium transplant that can be also effective. So of course, why would AI leave behind in the race of the advancements? Of course, AI can help us in sort of guiding the treatment and in, of course, screening and prediction about actually if the person has AMD or not. So about guiding the treatment choice. Research was conducted by a South Korean team, and if you can appreciate the figure A over here, the figure A was taken before treatment, before the use of anti-VEGF injection. That you can appreciate here that there is subretinal and intraretinal fluid. Now the human examiners examined the picture, the OCT picture, and they said that the fluid will reduce after the use of VEGF treatment. But the AI system actually, what it did, it generated an AI picture that is shown in the B figure. It said that there will be some residual fluid left in the subretinal space and the intraretinal space. And of course, AI predicted it right. When the results came out after the treatment, that is the figure C, there was some fluid left in the subretinal and the intraretinal space. So yeah, AI advanced till there. Next, AI can also help us in screening and prediction, and this specific study is FDA approved. The AI software is also available on net. You can also check it up online. And basically the graph, the flowchart that is shown here is kind of used, the AI used this software to screen or predict whether the person has wet AMD or dry AMD, or even also that if the AMD is high risk or low risk, as in to refer to an ophthalmologist or to call for a rescan after 1 year. So coming towards the inclusion, of course, wet AMD can affect life badly, and of course, since there are therapies available, anti-VEGF, but we need advancements. So of course, we are looking forward to that in the future. So thank you so much.
Thank you, Dr. Manaqib and your colleague. Now I would like to invite Sayyida Noor Sabah for her presentation.
Hello, Assalamu alaikum. I am Dr. Sayyida Noor Sabah, medical officer at Al-Shifa Cohort. Today I'll be presenting a topic about enhancing amblyopia treatment with virtual reality, a call for future research and clinical integration. The co-authors with me were Wajir Rahman and Dr. Sheila Khan. Amblyopia, also known as lazy eye, occurs when the brain doesn't process input from one eye fully, and over the time, the brain favors the other eye, which leads to a reduction of vision in the affected eye. The prevalence rate in general population is about 1 to 5%, and it is one of the most common disorder in Pakistan. Throughout many years, ophthalmologist has used traditional approaches such as patching, optical penalization, atropine, and binocular therapies. And these traditional approaches has given considerable improvement, but they only focuses on visual acuity and may overlook other crucial visual skills, for example, stereopsis, stereoacuity, and motor integrations. While the modern approaches, such as virtual reality, aims to focus on the entire visual systems and also target specific visual deficiencies, for example, strabismus and oculomotor dysfunctions. And these virtual reality methods are also engaging and interactive, thus enhancing motivation and improving the outcomes. Previous research done by Lee et al. In 2020 efficacy of intervention of amblyopia, a systemic review and meta-analysis compared the efficacy of various treatment for amblyopia using RCTs. The key findings were that penalization showed least effect in visual acuity, patching and atropine were effective, but there was compliance and dosage challenges, while binocular therapy showed no significant improvement. Before coming to our meta-analysis, let me give you a brief understanding about concept of virtual reality. Virtual reality creates a simulated experience that can be different or similar to our world. It immerses the user in a 3D dimension or computer-based environment and allows interaction of environment and object. Typically, it needs a headset, a head-mounted display, or digital screens. Let me make it more clear with examples. There are softwares and hardwares that are used in virtual reality. For example, games and movies. Dichoptic movies are animated films that improves visual acuity in amblyopia. Brain VT, visionary tools, amblyOplay, Dichopt, Vivid Vision, and IBIT is office-based or home-based therapies in forms of computer games or apps. Here's an image. Here's an image of virtual reality that is being used in an RCT, and it's available in the practice. It is used in practice, I mean to say. It's used for the treatment of amblyopia, strabismus, and convergence insufficiency in form of a head-mounted display. There are three types of virtual reality: non-immersive, semi-immersive, and fully immersive. Non-immersive uses only screen with a basic interaction, while semi-immersive and fully immersive uses a more immersive techniques, for example, a head-mounted display, and there can also be a full body interaction. Virtual reality in forms of amblyopia treatment shows that dichoptic training can re-imbalance visual input between eyes, binocular vision therapy for depth perception, and they also give an engaging visual stimuli for compliance. These are also home-based therapies, thus they are convenient. Here's an image. Here's a picture, and as you can see, that there's a change of lines between both of the images that are presented into the eye. Here's another image. There's a difference in contrast. The weak eye has a more contrast image and a brighter one, while the stronger eye is presented with a little low contrast. Previous research done by Shao et al. Measured the effectiveness of virtual reality in treating amblyopia compared to the conventional patching therapy. And the key findings shows that there was improved visual acuity, especially under children less than 7 years of age, and those that were presented with shorter intervention. Another study done by Chon et al. Measured the design and assessment of virtual reality techniques, for example, headsets, smartphone apps, and IBIT treatment to measure the amblyopia, strabismus, and myopia treatment. And it also showed an improvement in the virtual reality, but there were hardware limitations in form of resolution and field of view. As I mentioned before, all of the virtual reality that are used are in form of games, movies, softwares, and other trainings, but our meta-analysis and systemic review focus only on analysis of gamification in the virtual reality therapies for amblyopia. Our objective was to evaluate the effectiveness of gamified virtual reality for amblyopia. We wanted to know whether incorporating gamification in virtual reality intervention would improve patient adherence and visual outcomes. We only included those studies that showed a comparison between gamified virtual reality and traditional therapies, and excluded non-amblyopic studies with less sufficient data. We use PubMed, Google Research, and ResearchGate databases with relevant words and meshwork and Boolean operators. 2 independent reviewers screened through title abstracts and included only those studies that fulfilled our P-code. Here's our P-code. We selected 132 studies were retrieved, out of which 18 studies were selected. 9 were RCTs and 9 were observational studies. Here's a Prisma flow diagram, as you can see. In one study, 596 participants were included, out of which 227 improved in visual acuity. Custom-made action video games and dioptic training showed notable reduction in log MR, indicating enhanced visual function. While also log ASC stereoacuity was observed, which showed improved depth perception. Here's our studies that shows improved visual acuities. 15 studied mentioned that there was improved visual acuity. 2 studied showed improved adherence. 4 studied showed improved stereo acuity, and 1 study showed better stereopsis. Here are 2 studies that showed that 65% adherence was present among the individuals, and another study shows 87.5. Our results analysis showed that gamified virtual reality can boost the engagement system by reward, and hence improve visual acuity, stereo acuity, and also it can be used with patching and pharmacological intervention to give a better outcome. There were certain limitations, for example, heterogeneity, bias, and low quality evidence. Before ending my topic, I would say that we should adopt to the digital world and allow it to revolutionize our ophthalmology. Thank you so much.
Thank you, Dr. Noor, for teaching us about virtual reality. Now I would like to invite our last speaker, Dr. Zahra, for her talk.
Assalamu alaikum, everyone. From ancient couching to futuristic lasers, cataract surgery has transformed not just how we see, but how we live. I'm here to discuss the evolution in cataract surgery. So first of all, we move on to the basic understanding of the cataracts. In understanding of the cataracts, first of all, we're going to discuss the eye natural lens opacity. Cataracts are caused by the clouding of eye natural lens, leading to blurred vision and visual impairment. When it comes to the prevalence of cataracts, the prevalence of cataract varies from a figure of 1.6% to 35.1%. And it is a progressive condition, which means it develops over time. So now we move on to the symptoms of cataract. The symptoms of cataract include blurred vision, which seems like you're looking through a foggy window. Then we have light sensitivity, which shows like bright lights become uncomfortable, dull colors, the colors lose their vibrance, and night blindness, especially affecting driving and recognizing faces. So after a wrap up, I'm going to move on to the history of surgical techniques. In the history of surgical techniques, I'm going to put an eye on couching, extracapsular cataract extraction, and intraocular lens. So first of all, we have couching, and it was the earliest known method. It was performed in India around 800 BC, and it involved the dislodging of lens from its position into the back of the eye, and after that, the eye was just soaked into the warm milk and bandaged. So after that, there was an introduction to the extracapsular cataract extraction, and it was first performed in Paris in 1748 by Jacques Deville. So it involved the removal of eye natural lens, leaving behind the capsule that covers the lens. However, Deville's method got rid of the cataract. It also got rid of the eye natural lens, leaving behind the eye with unfocused vision. So then there was the introduction to intraocular lens. In the introduction to intraocular lens, like after being frustrated by the results of extracapsular cataract extraction, an English ophthalmologist came up with the idea of intraocular lens in 1940s, and it was not until 1950s that he placed one into the patient's eye. Okay, now we move on to the contemporary practices, or the practices that are performed nowadays. These include phacoemulsification. I'm going to demonstrate a short video on the phacoemulsification after this. Extracapsular cataract extraction, which is explained earlier. Manual small incision cataract surgery, which is an evolution of extracapsular cataract extraction, and it involves the removal of cataract from a small self-sealing scleral tunnel wound. And then we have femtosecond laser-assisted surgery, or FLACS. So here's a short video demonstrating phacoemulsification. First of all, the ophthalmologist makes a corneal incision onto the side of the eye. And from this incision, a pen-shaped instrument is inserted. This pen-shaped instrument breaks down the lens particles of the cloudy lens and suctions them out. And through the same opening, then there's an intraocular lens inserted into the eye, which remains there permanently, and which helps in focusing the light onto the retina on the correct position and helps us focus properly. So now we have flax. It is basically an assisted technique, like the surgeon use laser instead of the normal tools that we use traditionally. Okay, so after the wrap up onto the history and the contemporary practices, we're going to discuss the future innovations, which include intraoperative aberrometry with aura, stem cell therapy, artificial intelligence assistance, and nanotechnology integration. So here's an image demonstrating the intraoperative aberrometry with aura, in which it provides the surgeon with the real-time measurements of the eye during the surgery, and it's a good assisting technique for the precision. And then we have the stem cell therapy. The researchers are testing stem cells to regrow lenses instead of artificial lens, and it is very good to know that the full lens regeneration is achieved within a short time period of 8 months. Now we come to the conclusion. So we have seen how far we have come in fixing the cataracts from super basic to super advanced. It's clear the future is looking bright. Thank you so much for listening.
Thank you, Dr. Zara, for teaching us. Now it's the time for the shield distribution among the participants. I kindly request Dr. Shakib Anwar and Dr. Fawad Niazi to come on stage for the shield distribution. चले जी. Dr. Usama, please come forward. He has been declared number 1. Dr. Munakib, please come forward. You have got the 2nd position. Thank you, Dr. Munakib. And then Dr. Hamayo and Dr. Zahra, both are for the 3rd position. Please both come forward. Dr. Zahra and Dr. Hamayo. Thank you. With this, we end with the undergraduate symposium. Thank you, Dr. Fawad and Dr. Shakir. Thank you.